it can be useful sometimes to say, hey, look, you have this surrogative plaque, you're at higher risk, will you now take the statins? On the other hand, I also get what the other side is saying that, sometimes what actually happens is a coronary artery calcium is obtained in an asymptomatic person, leading to CT angiography non-invasively or invasively, and then downstream procedures and other testing and possibly anxiety. So, I actually see both sides of the argument there. I think that's why guidelines in the end are just, guidance, and physicians really have to see what they think the evidence truly tells them to do for the individual patient in front of them.
Welcome to HealthBeat, a medical news podcast series from MJH Life Sciences. I'm your host, Kevin Kunzmann. Today we'll be discussing new guidelines and a corresponding risk calculator for lipid and cardiovascular disease management with Sydney Jennings from Patient Care Online. We're also joined in studio by our special guest, Dr. Michael Nicholson of the Department of Pulmonary and Critical Care at Robert Wood Johnson Barnabas Health. Let's dive in. A coalition of leading cardiovascular organizations, including the American College of Cardiology and the American Heart Association, has released updated guidance on cholesterol management and the prevention of atherosclerotic cardiovascular disease, two of the leading drivers of mortality in the United States. Published this month, the recommendations place a renewed emphasis on primary care as the frontline for identifying and managing risk. At the center of the update is the PREVENT equation, a new risk calculator designed to estimate both 10 and 30-year cardiovascular risk using data routinely collected in primary care, from blood pressure and cholesterol levels to metabolic and kidney markers. The guidance also reintroduces clearer LDL cholesterol targets and expands attention to risk-enhancing factors like lipoprotein A. The goal is straightforward: catch risk earlier, treat it more precisely, and ultimately reduce preventable cardiovascular events. But translating that into practice is anything but simple. Today, we'll break down what's changed, how these tools are meant to be used, and whether primary care is truly equipped to carry it out. Michael and I are now joined by our colleague, Sydney Jennings, who has been covering cardiovascular medicine for Patient Care Online for 8 years now. Sydney, how are you doing today?
I'm good, Kevin. Thank you for having me today.
A lot of good insights that we get to share and highlight from your coverage today. But let's start at the highest level and just ask, what actually changed in the updated cholesterol and cardiovascular prevention guidelines?
Yeah, so the updated 2026 guidelines represent a major shift from focusing solely on cholesterol to the broader management of dyslipidemias, incorporating contemporary risk assessment and stricter treatment targets. Specifically, the updated guidelines establish specific LDL-C treatment goals for primary and secondary prevention. For primary prevention, clinicians should target an LDL-C of less than 100 milligrams per deciliter for patients at borderline or intermediate risk, and less than 70 milligrams per deciliter for those at high risk. For secondary prevention in very high-risk individuals, the goal is now less than 55 milligrams per deciliter. So the new guidelines really emphasize early intervention beginning in childhood and advocates for the use of coronary artery calcium scoring to refine treatment decisions. The guidelines also integrate recent clinical trial data to support the use of newer pharmacological therapies like PCSK9 inhibitors and bempedoic acid. The guidelines offer specialized advice for managing elevated lipoprotein, LPA, and triglycerides.
Excellent. Thank you so much, Sydney. And as you allude to, just a robust data set that we have available for cardiovascular medicine, born out of a lot of innovation in the last 20 plus years. Dr. Nicholson, again, we're talking about some of the leading causes of death in the U.S., ergo the priority behind, medicine advancement and, robust research that led to these evidence guidelines. How significant are these updates in terms of the potential impact for patients in the U.S.?
Sure, Kevin. And you heard from Sydney, there's a lot of significance to the nuts and bolts of the changes. But really, to me, two of the most significant things are the changes in the concept of how we're approaching managing these diseases. And this is reflected throughout all of medicine at this point in a lot of chronic diseases. So those two concepts are, number one, instead of being reactive to someone who has a disease, identifying someone who is at risk for a disease, identifying them early and treating them aggressively to prevent that disease from progressing, as opposed to getting there when it's too late and there's not as much as we can do. That's a concept that is being reflected in a lot of different specialties across medicine at this time. And it's really, really encouraging to see cardiology do that in terms of lipid management. The second part of that would be more personalized medicine. We're seeing across a lot of specialties, as more diagnostic testing becomes available, we're finding that we can look at more than just one or two numbers and say, for this patient who may have been just in a general group prior, what is this specific patient's risk factor? When you look at clinical trials, you see N's of 30,000. When you're in a room with a patient, that N is 1. So use this information to figure out exactly what their risk is, and that's what medicine is moving towards, and that's what these guidelines reflect.
That's very well put, obviously. Just the available armamentarium that's there now, everything is so tailorable. And of course, again, like we're talking about, all those robust data points, while beneficial, of course, for advancing therapy, it does come down to the one. So I'm really glad you put it that way. Sydney, one of the biggest updates is the introduction of the Prevent Risk Calculator, which we'll get around to playing with in just a little bit here. What goes into it, though? How different is it from what clinicians have been using historically to inform risk?
Yeah, so historically, the older tool was pooled cohort equations, PCE, and the new Prevent equations was actually developed in 2023 by the American Heart Association. And it's the first tool to really officially integrate cardiovascular, kidney, and metabolic CKM health into its estimates. Unlike the PCE, it also includes heart failure as an independent outcome, and it's validated for adults as young as 30 years of age, which enables earlier intervention. The calculator also requires core clinical inputs such as age, sex, blood pressure, cholesterol, diabetes status, smoking status, BMI. It also was built on a big data set of over 6.5 million US adults compared to the PCE's older cohorts. And the PCE was also frequently overestimated risk, and the Prevent scores run roughly 40% to 50% lower for the same patient. Race has also been removed as a predictor. Researchers found that those equations remained highly accurate across all racial and ethnic groups without race-specific adjustments. And for younger adults, the tool provides a much-needed long-term vision by offering 30-year risk estimates alongside the traditional 10-year score. And it also generates lower risk numbers, and which the 2026 guidelines have established new lower thresholds for starting medical treatment. And clinicians have shifted the categories so they can continue to treat the same high-risk individuals. Borderline risk is now 3% to less than 5%. Intermediate risk is 5% to less than 10%. And high risk starts at 10%, which was formerly 20% under the PCE. This update is also part of the new CPR model, calculate, personalize, and reclassify, which encourages doctors to first calculate the score, personalize it with factors like reproductive history or inflammatory disease, and then use the tools like calcium scoring to reclassify risk if a treatment decision is still uncertain.
That's very interesting. Obviously, the addition of cardioendorenal factors that come into play there. Of course, we can put a lot of emphasis on the impact of heart disease in the country, but we'd be remiss to not mention, of course, those corresponding issues that often impact the very same patients as well. So very interesting to see a more contextualized risk calculator available to us, even if it's providing scores a little bit differently. I think it's really interesting, the 30-year outcomes, and we'll talk about that in just a sec. But from your perspective, Dr. Nicholson, these risk calculators, when we're actually in the room with the patients and sitting down and talking about these scores, are they helping you guide decisions? Is it helping inform the conversation? Is it something that's being absorbed by the patient as, wow, I didn't really understand it until you put that number in front of me? How is it playing out?
Right. And that's a big part of this, is how does this help us interact with our patients? And it definitely does. My thought process is, when you have calculators like this, think of them as a tool and not the rule. And what I mean by that is, don't go just specifically based on what they say. These calculators are created in order to support good clinical judgment. So most of the time, we can identify as physicians who may be a high risk, low risk, moderate risk, right? This calculator is showing them what that means. It kind of pulls back the curtain for the patients and says, I'm recommending this medication to you because you're high risk. Well, what does high risk mean? It means based on all of this data that I've put in for you, you have this risk of having a cardiovascular event over the next 10 or the next 30 years. And it makes it real for them, because a lot of times patients are more concerned with the here and now. I feel okay right now. My numbers look okay right now. Why do I need a medication right now? This is a tool that you can show them to demonstrate, even though things look great right now, this is telling us that if you stay on this current trajectory over the course of the next 30 years, you're more likely to have something happen. And that's the conversation that's really productive with the patients, talking about, I can demonstrate to you in an objective way that your health is at risk going forward if we don't do something about this now.
It's pretty interesting, because I have exactly that thought of curiosity of, like, is that something that resonates more with a patient than say, like, this is something we need to immediately address versus let's start putting in the groundwork now to improve the trajectory. That's something you find resonates much better the long term.
Absolutely, because when you're sitting in the office with a patient sometimes, a lot of these calculators are going to be used on otherwise healthy patients who had some elevated lipid levels on a baseline blood work. And so that patient didn't come there looking to get a medication. That patient didn't come there thinking there's anything wrong with their health. And they're not going to fully appreciate that until you can show them, hey, yeah, maybe in the next 5 years something won't happen, but you've got 30 more years ahead of you. And that's what I want to think about with you as your physician. I want to keep you healthy. And that's something that does resonate with them a lot.
Sydney, again, knowing that you've talked to some of the cardiologists that have, shared some perspective around these guidelines or helped influence them with their own research as well. One thing that stood out was a particular excitement around the inclusion of lipoprotein A, LPA. Why is that? What were they really interested about that factor being added to this score?
Yeah, I had one cardiologist tell me it was fantastic, quote. And I think that they're excited because wasn't previously part of guidelines or they were abandoned by previous guidelines. And I think, and cardiologists have said that that was an error because they're just so crucial for effective patient care.
This is another atherogenic particle. It's an ApoB 100 particle, but there's largely stable nature to the Lp(a), meaning it's a lifetime type of measurement. So if you've measured it once outside of certain things, inflammation, pregnancy, etc., it stays relatively stable, but then it's also inherited. So it helps us to do what's called cascade screening. Well, Lp(a) then, why should we measure it? Well, if you get it in everyone, a universal screening, then when it's high, you can identify families where it's elevated and implement therapies so much sooner. And I don't mean just pharmacologic therapy, but optimizing lifestyle, making it much more real that you have risk and we have to really treat this seriously.
Really a foundational marker to inform exactly what long-term risk looks like, and maybe something that, as you're describing, is very influential in their, I guess, perspective on whether to take it serious to start investing in their health. Of like, there's something out of your control. It's a reality that you have to navigate. So everything else around it that you can influence, let's start working on that. That said, at the same time, Sydney, I know Dr. Deepak Bhatt was somebody who flagged to you that there's risk of sort of differing interpretation of the guidelines with as many variables as are at play with this. What exactly did Dr. Bhatt say to you about the primary care versus cardiologist split on these recommendations, the risk he sees of interpretation between those two focuses?
Yeah, he actually said, and this was a little surprising to me, that many cardiologists at his institutions largely ignore the no target guidance. But many primary physicians, he said, tended to follow it, partly because it made their workflow simpler.
I think targets are really important. I mean, every biological variable is a continuous variable. And, it's not that if your blood pressure is 119 over 79 versus, 121 over 81, those are basically the same number. Same with LDL, whether the LDL is 71 or 69. I mean, those are really the same number, obviously. But I think in actual clinical practice, in terms of implementing guidelines or just implementing good evidence, clinical trial evidence, having targets is really useful. With the guidelines that moved away from that was an enormous strategic error and also enormous lapse in common sense, and a good example of how guidelines can actually mislead and provide poor guidance. So that's why physicians always have to take guidelines with a little bit of a grain of salt, because sometimes it's only in retrospect one can really figure out what was good guidance and what wasn't. But not having targets was really a bad idea. And I can understand level of evidence. One can debate for things like what a LDL target should be at the time those old guidelines, did away with them. But that doesn't mean get rid of the targets. You could say, the evidence isn't from randomized clinical trials that a specific LDL target is beneficial. Again, that was at the time. Now there are such data supporting targets as well. But at the time, sure, one could make that, sort of esoteric argument. But again, is that something that's going to help patients or hurt patients? It definitely hurt patients. And, most cardiologists that I knew disregarded those guidelines, abandoning the targets. I actually don't personally know anyone that followed that advice, but lots of primary care physicians followed that advice because in some ways it made life simple. Start with statin and don't measure the LDL again. That's not exactly what those guidelines even said, but that's how they were interpreted. And have to be careful when you come out with a message that you're thinking, oh, we're so evidence-based, but how is it going to really play out in real life? So, that was an example of a fumble in those guidelines. And I think these guidelines have corrected it. On the other hand, these guidelines have generated their own set of controversy with respect to even things like Lp(a) that we chatted about a little bit, though there, we're going to have an answer soon in terms of specific therapeutics. And as I said, as a risk marker, the data are quite strong.
As a specialist yourself, what do you read on that discrepancy, like especially for a comprehensive evaluation like we're working with? How feasible is it for primary care colleagues to adopt and implement that sort of practice today?
Yeah, and I totally agree with the idea of the guidelines that preventative medicine starts with primary care. That is the foundation of our healthcare system. Unfortunately, with the current system that's in place, patients are getting more complex, diseases are getting more complex, guidelines are becoming more nuanced, and the only thing that's not changing is primary care doctors are not getting longer office visits with their patients. So primary care doctor is sitting there with 6 or 7 things to tackle in a visit, all becoming more and more complex with time. They don't have the time to talk to the patient in depth the way the patient deserves to understand their health, and they don't have the ability to do that for a variety of medical problems they're treating. And I think that's where we come in as specialists. I think for the benefit of patients and our primary care colleagues, we need to offload some of this burden from them. For example, I really enjoy when I have a primary care colleague who will send me a referral specifically for tobacco cessation counseling. It's one of my favorite visits because there's a primary care doctor understanding and identifying a huge risk factor for this patient's health, but knowing that they don't have the time or the means at this visit to talk to them about it. This patient can come to me, and now I have 20 minutes to only talk about this one topic, which might be the most important decision this patient makes regarding their health in their entire life and deserves that time. So I don't think that primary care physicians are going to be able to implement these guidelines well, but I think what the guidelines help them do is identify patients who should see a cardiologist to have a more in-depth discussion about this. And I think that's kind of the bridge between making these guidelines and these calculators more relevant, more easy to implement, is having the primary care doctors identify the risk, but the conversations and the medication management coming from the specialist side of things.
It's almost like the pathway into care has really evolved of late, where primary care now serves as more of a conduit than the host of that intimate conversation. And it's really just hitting the escalation button to that intimate conversation that has to be hosted by a specialist now out of necessity, and just continue to facilitate and field up front. So with that in mind, in a practical effect, something like this, is this going to make prevention more precise for patients, or is this going to be something that sort of complicates the primary care process, or do you feel like they're equipped?
It's almost like when we get all of these new complex guidelines in all medical specialties, it's really a double-edged sword. It's great because we have this great new robust data set with personalized care for our patients that make evidence-based recommendations. But on the side of that, then our patient care gets more complex, meaning there's more variables and there's more decisions. Primary care doctors and specialists alike, we're making hundreds to thousands of decisions on a daily basis. So adding more decisions into that can sometimes be overwhelming. So I think what it comes down to is understanding what patient should see a specialist versus which patient is comfortable enough with their primary care doctor. Maybe this is their one problem. Their primary care doctor can have the conversation with them. But in a lot of cases, seeing a specialist allows us to identify the patients more precisely. And there's more nuances within it that we understand about our organ system as a specialist that we can communicate with the patient and that we understand outside of just the calculator. So what I see with this calculator is more of a flag to say, hey, this is someone who deserves a little bit more precise medicine. And that kind of serves as the bridge to allow that precise medicine from the calculator and the guidelines to be implemented more effectively.
And of course, I know they've set up logistically for it to be embeddable into EHR. So logistically simplified a little bit, but again, just another factor to consider. And as long as you've adopted, as you're describing, the right systemic mindset with what does it mean when X score comes in for X patient, then you should be operating still smoothly, hopefully.
Definitely.
But, yeah, we'll have to say. We were talking just before, obviously, around you find a lot of valuation behind a 30-year risk calculator. What exactly it provides is a pragmatic conversation to host with the patients. It's something that resonates. Do you have any more insights into how you think those conversations should be hosted, say, exactly as you described before, a scenario where the primary care physician says, actually, I do have the time. I got the time today. This is the one thing that came up on their scores, their assessment that gives me a little pause, a little concern. I'm going to spend the 15 minutes working on that. Do you have any advice on how to host and launch that conversation?
Absolutely. One of the analogous situations I think that I have a lot in my practice is patients who are currently smoking and will do a pulmonary function test and they don't have COPD. And so they tell me, why do I need to stop smoking? I don't have COPD. My lungs look great. You did the test. It's right there. And that's a fair mindset to have. Your lungs do look great right now. That's a moment for me to say, this is all the more reason for us to stop smoking right now. And I can pull up graphs that I have in my office, which were some great studies done in the past showing lung trajectory over time, lung function trajectory. And what they did was comparing people who haven't smoked to people who continue to smoke to people who smoked and then stopped. And what those studies showed was that patients who smoked lost at a faster rate than patients who didn't, obviously. But then those who stopped went back on the regular lung function, just age-related lung function decline. So to pivot that back to this topic, you can inform your patients about what do they not want, right? In my case, they don't want COPD. They know it's a risk factor of smoking. In this case, patients don't want heart attacks or strokes. And as the provider, you can inform them, yes, maybe right now, things look okay, you feel okay. But 30 years down the line, this score is saying you might become one of those people you're afraid of becoming, who needs stents, who needs an open heart surgery, who has a stroke and can't move the left side of their body. That's the big fears of patients, and these calculators are showing us a risk of that happening over time. Nobody wants that to happen, whether it's now or in 30 years or in 10 years. And so these calculators are a tool for communicating what the risk really means to patients.
Maybe if we could just open it up a little bit and actually see what it looks like. Sydney, if you don't mind, I want to give you a hypothetical patient for us to sort of see what exactly their risk score looks like and what exactly this is providing us as some insights for clinicians. You want to pull that up for us?
Yep, let me share my screen.
Cool. Okay, when you're ready, I'll give you our patient read, okay?
Perfect. Ready when you are.
Awesome. Okay, so let's say we have a 46-year-old man. I didn't give him a name, so feel free to. Ted. Ted is a 46-year-old man with no history of heart disease nor diabetes. He's a non-smoker. Good job, Ted. With a systolic blood pressure of 129. Let's give him a cholesterol of 257. But then his HDL and EGFR are pretty solid. Let's say 58 and 93 for those. So we're looking at someone who's overweight, borderline hypertensive, high cholesterol, but adequate HDL and EGFR numbers, no other prior history. Let's see exactly what it tells us for what we should expect for Ted here. Okay, so 10-year risk score, 2.6% for cardiovascular disease, 30-year score, 17.6%. ASCVD, what do we see? 1.9 and 12.3. And then we had an option for heart failure, much lower, which is good to see. But all the same, again, Dr. Nicholson, as we're talking about, pulling this up and having numbers to look at and digest for our patients, what's going to really inform the long-term treatment plan here as a clinician, and what's your immediate priority for them?
Right. And I think this is a really good example of where the calculators can be helpful to support clinical judgment, because you have this patient who's young and he has a modifiable risk factor. We can modify this with medications, and the guidelines do a really good job of pulling in these non-statin medications in addition now to be more aggressive as well. So this is somebody who you can identify early. If you were just looking at a 10-year risk calculator, you see a small number, maybe you say, oh, I really wanted to be aggressive with this patient, but now I won't because it's small. And the patient might say, yeah, this is a small risk. I don't want to be on a medication with side effects. But when you pull in that 30-year number, it's so powerful to show those patients, and it's so powerful to support your judgment of the clinician to want to react early so that you don't react late when the patient's already had an event or when that risk score is much higher in 10 years. So my priority for this patient is to aggressively manage them at this point with lifestyle changes, medications, to make sure that we reduce that risk, because it builds silently over time in the background.
Right, right. And that's the clearest message, right, we can give someone like Ted is like, hey, you're looking at the roll of a dice. Do you really want to roll it, or do you want to just mitigate that risk right now? You want to do some things day to day that's going to get rid of that risk and scare down the road. Let's pivot a little bit to ask you both again another question. Over the next 6 to 12 months, what should we be watching for in terms of how widely these guidelines and tools like Prevent are actually adopted in practice? And I'll stay with you, Dr. Nicholson.
Sure. I think the biggest thing will be the feedback from our colleagues. 6 to 12 months, we're not going to be looking to see any major changes in the health of the general population of the country. This is most powerful in decreasing our ASCVD morbidity and mortality over 10, 20, 30 years, not 6 to 12 months. In 6 to 12 months, we're going to have feedback from other doctors saying, hey, this is too much that I'm using in the office, or hey, this is working greatly, or hey, this would be a great way to implement this into the EHR. And I think the biggest feedback that we should look for is what we touched on earlier, which is how do we make this really complex, nuanced, personalized thing easily accessible, interpretable, and actionable? And those are the things that are going to prove it to be a real success in the end, because just like in pulmonary medicine, our lung cancer screening programs, our nodule programs, right? Those are things that require a lot of decision making. Those are things that have a lot of different variables to them, but they're very easily implemented to our patients in our radiology centers and our radiologists and our thoracic surgeons and our oncologists. And that's why they've been so successful.
We really want to hear systemically, no real headaches, no real hiccups in terms of implementation. And if anything, rollout has been slow and steady, and hey, we're not losing footing on this. It's actually applicable,
right?
Really is what we're wanting to see. Anything different from that or complementary to that you've heard, Sydney, and covered so far?
Yeah, I think another thing that would be interesting to see is the integration into EHRs. The American Heart Association has made the source code and calculation documentation available, but the widespread availability of these calculators within the patient chart is essential for moving Prevent forward. And I think it'll be interesting to see how it gets integrated into EHR, because we know sometimes electronics is not the best, and there are EHR is also not a perfect model. So I think that'll be interesting to see how it gets implemented and how physicians feel about it being implemented. I think it'll also be interesting to see the implementation of universal LPA screening or testing, sorry.
Absolutely. And obviously throughout the episode, we've been really pinpointing, some insights from the cardiologist experts, of course, who help drive and inform this idea in the first place, not to deprive your audience and your thought leaders at Patient Care Online, who are primary care focused. Obviously, that's going to be the fallout conversations that are occurring here, as you described, Dr. Nicholson. What are you hoping to gain from conversations with them and tap into as we, return to this topic over the next few months?
Yeah, I'm interested to see how the Prevent equations are going for them, how they're implementing it, if they're finding it easy, if they're even using it at all. I think that would be really interesting to see, because as we know, and as we've said in this episode, primary care physicians are busy. So I think it'll be very interesting to see how they feel about it. And, it's another calculator that they have to use, but I'd be interested to see if they think it's easy to use, and if they use it in shared decision making with their patients as well, if they share the risk calculator with their patients and encourage patients to use the risk calculator. I think that would be very interesting to see. And I'd also want to hear from them about how the CPR framework is being integrated into their daily clinical workflows. I think that would also be very interesting.
Keeping in mind, again, Dr. Nicholson, these are guidelines, this is guidance, these are boundaries, guardrails to play with. It is not a firm black and white issue. Nothing ever really is in medicine. It's all gray, right? For the gray circumstances that may occur with consideration to the Prevent calculator risk, in moments when maybe clinical observation and insights maybe go against what a number says to you, any recommendation or key totem for people to come back to as a mindset when navigating these?
Yeah, I think it's always about keeping your patient informed, discussing with them and being honest with them. The best thing to do is pull back the curtain on everything that you're doing as a physician and say, hey, look, there's this calculator that came out. This is what it's saying. Whether one way or the other, you can have a patient that says it's low risk and admit to the patient, this is not going to ever be able to precisely predict you. It's good. It's based on a lot of data, but there are things about you, inside, outside, environmental, that this calculator can't account for. So we need to make a decision together as a team based off data, but also based off your goals of care, my clinical experience and expertise, and figure out what the right path is for you. And I think I used the line earlier that I'll reiterate, which This is a tool, not the rule, and it gives you some great guidance. But at the end of the day, it's you and the patient in the room, and we have a lot of great physicians who can trust themselves in their clinical judgment.
And if anything, this could be a great educational prompt for patients as well.
Sure.
You're going to get fielding questions. What is a lipoprotein A? What do you mean there's good cholesterol? What's HDL? What does the EGFR number mean? It's going to lead to a lot of contextualizing conversations around the fulcrum of health that really makes up cardioendorenal disease. So
Absolutely.
It's going to be interesting to see. And I just appreciate you both being on to, sort of host at least the launch of the conversation, and hopefully more to come down the road.
Great. Happy to be here.
Absolutely. Absolutely. Thank you for coming on as well, Sydney.
Thank you for having me, Kevin.
That is going to be all that we cover on the new Prevent guidelines and the risk calculator today. But you can follow Sydney Jennings on LinkedIn, and you can read all of her coverage and content surrounding this and everything else into primary care related cardiovascular insights at patientcareonline.com. You can also follow Dr. Michael Nicholson on LinkedIn. Check out the show description below for all the links and resources that we referenced today, including Sydney's interviews with Viet Le and Dr. Deepak Bhatt. And if you're interested in more primary care news and insights, you should check out our new series, Primary Care Lens, hosted by Dr. Jabril Oyeyemi on patientcareonline.com. For the Health Beat, I'm Kevin Kunzmann. Thanks for listening in.